Hi, and welcome to the podcast. My name is Jason Hooper, and as always, we're here with John Brissom.
How y'all doing, everybody?
Hope everybody's having a good time. Today, I'd like to talk about some ideas surrounding our healthcare system and sort of the interaction between medical practice and medical research. And everybody seems to be able to point out these big differences between the two and how there seems to be a big disconnect between the two. And I have some ideas today that I would just kind of like to talk with John here and think about some of the things that may be causing problems. So this idea that I've been thinking about quite a bit recently is the difference between science and medicine. And medicine, and we'll discuss this as we go, but medicine and doctors, I don't know, John, do you consider doctors to be scientists?
No, not the slightest bit.
Okay.
Why would I? Well, I mean, I'm not saying that some doctors can't be scientists,
right.
But on average, most doctors aren't. They're diagnosticians.
Right. I mean, you could have a doctor that's also a scientist, just like you could have a firefighter that's also a scientist. You know, they could just have dual backgrounds, dual occupations. But
it's rare.
The profession of a doctor, I think, is more of they're more related to the field of engineering rather than the field of science, because in science we're trying to look at the world and we're trying to see the world in a specific way and discover more things about the world. In medicine, they're trying to fix problems. You know, they're trying to. It's outcome based. Whereas if you're trying to be a scientific researcher and you're outcome based, well, that's a big problem because you should try to go into everything with an open slate. And so what's the big deal? You know, what's the big deal between medicine and science and how they interact? You know, why is there such a big problem? And so let's look at it this way. With science, they explain things categorically, just like everybody explains things categorically. But in science, they use classical categories, okay? What is a classical category? A classical category has a set of inclusion materials and a set of exclusionary materials. So, you know, like a triangle must have three sides. You know, they must have angles that equal up to 180 degrees. You know, it's very inclusionary, exclusionary. In medicine, they don't have inclusionary, exclusionary categories. They have familial categories. And if you look at the diagnostic textbooks like the Hay and the Merrick and the, you know, symptoms to diagnosis, et cetera, that's the basis for diagnosis is familial categorization, where researchers assume homogeneity. You know, they think everything in that category is the same because they've defined it using inclusionary, exclusionary criteria. So let me just give an example of why this is a problem. Okay, you have three different patients, patient 1, 2, and 3. Patient 1, according to the diagnostic guideline, if a patient has up to 4 symptoms, then they are categorized with the pathology. So patient 1 has symptoms A, B, C, and D. Okay, so they meet the criteria. Patient 2 has symptoms C, D, E, and F. Okay, so they meet the criteria. And patient 3 has E, F, G, and H. So patient 1 and 2 share the symptoms C and D, and patients 2 and 3 share the symptoms E and F. Okay, and they all have been diagnosed with the same pathology. Yet patient 1 and patient 3 do not share any of the common symptoms. Okay, it's because it's a familial categorization and not a classical categorization. So when we see a research study, we see a peer-reviewed journal study that's done on people with something like irritable bowel disorder or something like that, irritable bowel disease. Well, that's sort of a very broad diagnosis, and a lot of symptoms will come up, and you might have two different participants in the study that really don't have anything in common as far as that pathology goes. But the researchers, they assume homogeneity. They assume that everybody in the sample, everybody in the study is the same. And I think this kind of skews the research a little bit. What do you think about that, John?
I agree with you, but I would still argue that most of the research is light years ahead of clinical practice.
Yeah, it seems to be that with I mean, that's one of the disconnects. It's like the research seems to be suggesting certain treatment methods having a higher efficacy and using treatment methods that are not reliably used in clinical practice. But so I think the reason for that, the disconnect the other way, is because the snake kind of starts to eat its tail. The researchers look at the work they have to use the work of the physicians to have research subjects, right? And then the doctors have to use the work of the researchers for their medical practice. Well, you get in this loop where the doctors are generating research subjects that don't necessarily match the classical categories, and then they pump out data that's not necessarily going to work on every patient that's being diagnosed using familial categories. So the doctors don't necessarily trust the latest and greatest research coming out because sometimes it might not be good. And sometimes they just go with what's working in the field and not necessarily what's showing up in the studies.
They go with what they're taught, and it takes forever for medical textbooks to be revised with knowledge that researchers have known forever. I mean, how many diseases have we talked about, whether it's mycobacterium or bacteria, should I say, or microbiology? Have we talked about whether microorganisms, whether it's Mycobacterium avium paratuberculosis or H. pylori or anything like that, where researchers knew that it was probably the cause of certain diseases for years, and then it doesn't, get updated into the medical textbooks, or let alone doctors and clinical practice for decades. I mean, there's definitely a issue with that disconnect there, and I do agree with you that sometimes researchers try to make everything fit together in a nice, neat package to deal with their previous proclivities. But still, I mean, the doctors are worse, in my opinion, when they don't, like you said, well, the research is new. Well, I can understand someone saying that about treating ulcers, H. pylori as a cause of ulcers in like 1985, but I can't for someone in 2001. It's just too long of a time period. There's too many replication of studies since then. It's ludicrous.
Do doctors necessarily need to know the cause of the pathology?
They do. Yes, they do, because they won't treat it otherwise. You know that.
Well, what if they just recognize the symptoms and they're able to make a diagnosis and provide a treatment? Let's say they prescribe an antibiotic and they don't know which bacteria is causing the problem. Well, there's a chance that they don't use.
So you want your doctor to be a parrot, to repeat back? I mean, you don't want them to be very free thinking and be able. That's the problem with it. Is it's all, they go to medical school, they learn certain time tested standards and norms within their books, and then they don't stay up anything. Not all doctors are like that, but a lot of them, they don't research any up to date medical studies or anything like that. So they're left with, I mean, what are we going to talk about here? Epstein-Barr, being the, looked into the cause of chronic fatigue in the 1980s, and then, the studies being mixed until the early 2000s, and, doctors pretty much say, well, it's not the cause. And they come back and look and see those studies were flawed, and later look and say, well, maybe Epstein-Barr can lay latent in ganglion cells and B cells, and then, the modern research that we have nowadays reproving what they knew back in 1980s to be correct. I mean, that's a lot of my problems with the medical profession, is if it walks like a duck and quacks like a duck, 9 times out of 10, Jason, it's a duck.
Mm-hmm. Yeah, but the thing is, I guess the a priori error is that we're classifying, like when scientists classify a duck, then they're looking at, a species of animals that can breed with themselves and create viable offspring that can also breed. It's an inclusionary exclusionary criteria. And if we don't necessarily in medicine look at things causally based, because they're familiar relationships. So it's like we're naming things familially that are non-scientific in order to, number one, give somebody a name for their condition, which is an extraordinarily powerful thing. Because if you don't know what you have it's terrifying, right? You're
Yeah.
feeling terrible.
Yeah.
You're suffering. You have no idea what's going on with you. And as soon as you get a name for what's causing your problems, it's just immediate relief. And you're like, oh, I
Well,
had this.
I saw that with my son Abel when they
Mhm.
had no idea what the heck was wrong with him genetically, and then finally, one doctor at Mayo Clinic happened to see his condition, which there's only been 5 children diagnosed in the world with it at the
Mhm.
time, and they gave it a name which is congenital myopathy with excess muscle spindles. Now, granted, they didn't even give the name of the doctor. They gave exactly what it was, but from there, I knew what I was dealing with and had hope that maybe I could research it and help him overcome it. So yes, if you have these symptoms and you have no idea what's wrong with you and there's no pathology for that, yeah, it's utterly terrifying.
Yeah. And yeah, like you said, you can connect with other people who also suffer from the same diagnosis, and there you can go online. There might be support groups. There might be, I mean, it's just, there's a lot of power in that. But again, it's not a classical categorization. So you might not share the same symptom. You might not even have the same cause for your diagnosed disease. And so there may be an advantage to treating things functionally rather than necessarily causally. I want to give you an example of, we did that podcast on the flu, which outraged a lot of people, which was not surprising to me because ideology just seems to take over. Even though
People lack critical
well,
thinking.
yeah, I mean, I'm vaccinated, you're vaccinated, our kids are vaccinated, we're not anti-vaccines, and yet people went nuts over this thing, like criticizing the problem with the influenza
Hey, I
vaccine.
will say Holden was vaccinated, Abel was not, and Amelia was vaccinated against certain things.
Yeah.
So it's a little bit of a difference, but yes.
Yeah. But anyway, okay, so looking at the flu, we believe that influenza is caused by a virus, right? That's the cause that
Yes.
we believe. Now, can we absolutely prove that 100%? Well, we have a pretty good working knowledge of how that happens. But are we 100% sure? I don't know.
No.
Yeah. So,
No.
but we assume that's what's going on. Okay. So, how is the flu diagnosed? Well, we can diagnose the flu symptomatically and because it carries a set of conditions. Well, we can also look at the flu genetically, and we can see if we can find the virus, or we can see if we can find antibodies that are floating around which would correspond to the flu. So there's something called the rapid influenza diagnostic test, and it's a test that can be performed, and you can get results back in I think it's like it's around 15 minutes. Let's just say 15 minutes. They go into they take a sample, they go into the back, and they run it through the test. I've looked at different reports, from the CDC. We'll just use the CDC. Other reports, have different levels of accuracy. But when you compare this to an RC-PCR test, which is the gold standard for basically you capture the viral shell and you run it through a preliminary chain reaction, and you can look at its genes and determine what it is. You use the rapid influenza diagnostic test. In 62.3% of the time, it agrees with the RT-PCR. So that means 37.7% of the time, it disagrees. Now, the problem with the RT-PCR isn't that it's expensive or that, it is more expensive, and it isn't that it's more technical and you need more facilities or whatever. The biggest problem is it takes at least 48 hours to culture it and to run the tests and to get the results. Now, by the time you have the flu and you're sick enough to go to the doctor, 48 hours later, you're going to be darn near through with it and you're not going to care anymore. So treatment is going to be 48 hours delayed. And it's like, should we just assume that they have the flu because they match the symptoms, or do we really need to go after the cause?
No, I agree with you. I mean, I do that a lot when I consult. I don't see any issue with that.
Mm-hmm.
I would recommend giving the person elderberry and zinc and echinacea and see if they get better.
Mm-hmm.
They get better in a few days, and they feel better. Then in high dose vitamin C with that too, then it was more likely they had the flu. If they don't get better and in fact either get worse or it persists more than 7 to 14 days compared to the severity of the symptoms, then yeah, it might not be influenza. It could be something else. I don't necessarily have an issue with that. My issue with diagnostic medicine is that the research shows, and it's not just like one or two studies, it's a replication of studies throughout the many years, and it takes them forever for some reason or another to start tackling disease as such. I mean, what about herpes simplex 1 being the cause of Alzheimer's disease? I mean, they've known the connection between Alzheimer's disease and herpes simplex 1 since the early 90s, and since the Journal of Medical Virology in 1991. And in 1997, in the Lancet, there was a study that had linked APO4 to HS, to herpes simplex 1. So researchers have known about this, and there's been enough replication since then, especially in the 2000s, where when you look at the news reports on Science Direct, or wherever you get your news from, they'll act like in the past year or two, oh my God, this is something new. They've discovered the connection between herpes simplex 1 and Alzheimer's disease. This is going to mean breakthroughs for the treatment of Alzheimer's. Well, hell, Jason, they've known that for, early estimates, at least almost 3 decades. If you want to go based on a conservative, I guess maybe a decade and a half. And yet they're not doing anything. Like, why is there such a huge gap between it? It's ridiculous.
So you think that they should be treating Alzheimer's with like Valtrex or something?
I would recommend that they would probably do it. Yes, if the activation is severe enough, or if trying D-limonene or low arginine, high lysine supplementation, high dose vitamin C, if they wanted to do it more integrative. But yeah, they should be. Now, does that mean that it's going to completely reverse Alzheimer's disease in some people? No, because it seems to be a disorder where the amyloid plaques form with aluminum, and the immune system trying to fight the HSV. So there could be some permanent damage done to the brain that we're unaware of. But especially with people with early Alzheimer's disease, or people who know that they have HSV, herpes simplex 1, and APO4, they should be taking PQQ to prevent the activation within the brain to prevent Alzheimer's disease. This is preventive medicine that doctors could do, and the studies are there, but they don't do it because the research is light years ahead of clinical practice. And would you ever see a doctor writing a prescription for 20 milligrams of PQQ to give somebody who was tested for APO4 and had, because they have herpes simplex 1 to prevent its Alzheimer's? Do you ever see that ever happening, Jason? I sure as heck don't.
No, I don't even know if there is a pharmaceutical company that's producing PQQ as a medication. I might be wrong, but I haven't really looked at it.
But isn't that the problem? What we're getting down to the heart of this is,
well,
there needs to be an integrative approach between researchers, doctors, integrative medicine. There needs to be this cohesive, and there never will be. There won't be, and it's sad because people are suffering. And now you can look at conspiratorially that pharmaceutical companies, insurance companies are getting freaking rich on the system the way it is now. So why in the hell would they do that? But it blows my mind. Why is there such a delay? Is it because the doctors are just ignorant and because they're taught from textbooks that are outdated? Is it because, what is it?
Most of the physicians that I know, textbooks are being constantly updated, and one of the reasons for that isn't necessarily to put the latest and greatest knowledge in there. But
they are getting updated, but they're not getting the newest research or any, they are updated every year. I went to college, I know that, or every other year, depending on the textbook. But that being said, they're still not giving the newest research. Doctors would have to, if you're going through medical school, you don't even have the time to, but I would suggest that people training to be doctors or going to school to be doctors should be reading those journals on their off time, if they ever get a chance to.
Yeah. This statement's going to be biased because, it's from people within my social circle, but the physicians I know, like I mean, they're on PubMed just about as much as I am, and they get fascinated with
No,
the
there's
research.
no way,
Oh yeah.
Jason. If they were, then they would know this stuff and they would practice it. I maybe some doctors, if they're very, I know I've known a few that were very, very good at what they do, but most doctors, they go to work, they look up something on a computer, if it matches the symptoms, and they prescribe the same medication. I've seen it day in and day out, and you have too with your own family members. Don't tell me that's not the
Well,
case.
the thing is, like most of the time, like it depends on what their practice is. Okay, so if they're just like a general physician or something, and they just have patients coming in, it's kind of a boring job. I mean, you don't have to be Dr. House to figure out what's going on, because like everybody who's coming in has the flu, because the flu's going around, or there's a cold going around or something. And so it's not like they need to be on PubMed for that. But I'm telling you, like the friends that I have who are also physicians, they research, they share their research with me. They talk to me, just like you're talking to me right now about this kind of stuff.
So when I went to the Alzheimer's walk,
Mhm.
because a friend of our family's, I had to do it for my wife's work, that he had Alzheimer's disease. They were, talking about one day we're going to have a cure and everything. There was the APOE, well, I asked around, it was known, and herpes simplex was not known at all. And they even had a research table with the most up to date researchers, so they said, and there was nothing on this. Like, you can say what you want, man, but I mean, I know there's some neurologists that probably know of the link. Just okay, for example, I'll give you an example. I coach people with guts. Okay, I mean, fix your gut. That's what I do. Most gastroenterologists are clueless when it comes to the microbiome, Jason. Utterly clueless.
Well, let's come back to that, and I really want to come back to that. But let's just talk
Okay.
about Alzheimer's research. Okay, so there are researchers that are going in different directions, and they kind of reach a consensus based on their findings and popularity of knowledge and how they can treat. But a lot of people thought for a long time that it was the beta amylase that was the issue. And then that kind of got debunked, and they started looking at tau proteins. And, it's like as the contributing factor to in how the misshapen tau proteins kind of like, they don't quite stack up right. They kind of spread out, because of if you look at like chemistry and you look at like electrical charge and shape, it makes a big difference about how different molecules are going to interact and line up. And so it's like, okay, these proteins are kind of, they're shaped a different way, and so they're not stacking up quite so neatly, and that's why they're causing plaques. Well, none of that has anything to do with a virus, or it's like the causality there is completely independent from herpes simplex, and that's kind of like the trend in where they're looking right now.
No, I disagree with you on that, actually. The herpes simplex was the way it interacts with the immune system, causes the blood-brain barrier to become more porous to allow aluminum in.
No, aluminum is only present because of when you have a lack of blood flow, then oxygen is no longer transported to those places in the brain. And so aluminum deposit, like anybody who's ever done any kind of welding.
But a person with a healthy blood-brain barrier, aluminum just doesn't get in.
Well, my friend, no, it does. A friend of mine was just working on. He bought a salvage Audi R8, which is like a really fancy sports car, but he bought it dirt cheap because it had a crack in the frame. The earlier model R8s had a defect had some kind of suspension effect to where it would eventually break the frame over time. So he had to have a master welder come through, and he had to take and compress the frame back into shape, and have a master welder weld it. Well, the frame's made out of aluminum, and aluminum is very tricky to use, because if there's oxygen present, then aluminum won't bond, and so you have to get it to a place where you remove all the oxygen for the aluminum to stick. So anybody who knows anything about welding will look at the whole aluminum hypothesis in the brain and be like, oh, well, we obviously know it's just it's just hypoxia, and that's what's causing the aluminum deposits. It's not the aluminum that's causing the Alzheimer's. Nobody thinks that.
I don't think that either.
That would have nothing to do, even if with the herpes simplex theory, or with the with the tau protein theory, like whatever you're going to go with on that, aluminum doesn't factor into any modern theory. It's just a coincidence that the aluminum is just depositing there.
I agree.
But okay.
I agree with you on that.
So let's talk about gut health, because when you look at gut health, which is what we sort of specialize in, we're looking at at pathology. What is pathology and what is healthy? And that's another big issue in medicine, because it's like, okay, if you ran my gut, right, and you just biopsied everywhere, could you find Klebsiella?
It wouldn't be in everyone's, but it would be in some people's, yes, as native flora.
My point is, like, you could find a lot of bacteria that we would consider to be pathogenic, right?
Of
And so
course, there's
if
tons of
you look
pathogenic
at this
bacteria.
if you look at this classically, and you're like, oh, somebody has Klebsiella overgrowth, well, that's not necessarily deterministic. We're not necessarily going in there and discovering that. We're assuming that based on symptoms. It's like, oh, they got really bad joint pain, and they seem to be really reactionary to certain foods and whatever. It's like, okay, well, that sounds a lot like Klebsiella overgrowth. So again, we turn it into a familial categorization based on the pathology. But at what point would we assume that someone is no longer healthy? And like, when is somebody healthy and when is somebody not healthy, and who makes that determination?
Doctors.
Yeah. So, well, a doctor will, I guess they'll say, like, you're in good enough health or whatever, but like, where's that line between, and like, what is pathology in the first place? Like, how do we assume pathology? Is it the amount of suffering that somebody's going through that would indicate pathology? Or is it biomarkers that we can find, or is it biopsies? Did we find some sort of material? Is it a CAT scan? Is it an MRI? Like, what determines pathology? Because there's a lot of people who meet the criteria for suffering, and they're going around and they're going to doctors, and they would probably meet the pathology category for suffering. And it's like, I'm in a lot of pain. I'm in a lot of discomfort. And they do tests, and the biomarkers don't seem to agree with the level of suffering. And so they don't get treatment. Or maybe vice versa. It's like, you're not suffering at all, but you go into the doctor and it's like your cholesterol is super high, and they're like, oh, we got to treat this. This is not good. We got to give you Lipitor. So the whole idea, when we're categorizing things, like, what is pathology? That's a big question in medicine. How do we determine if somebody is sick and worthy of treatment in the first place?
Okay.
So it's like, well, I think the mistake a lot of people make is when they say, well, okay, if part of your biology is not performing its designed function, then you're sick. And it sounds fair on surface level. It's like, okay, that sounds fair. But then you look into it deeper and you're like, no, that's 100% garbage, because biology does not design function, right? And biology is not teleological. Okay, we infer function from what we're seeing in the biology, but it's like, what's the function of your tongue? Well, it has tons of different functions, right? You can use it to talk. You can use it to taste. You can use it to, do all sorts of things. You can use it to lick paint off of a wall if you want to. Like, what is the function of a tongue? It's just a tongue. It doesn't have function. It's just, that's the way the biology is. And so it's like, well, it's not performing its designed function. No, that's your inference. You're inferring a function from this, and you're trying to say that it doesn't meet that criteria. So then again, like, goes all the way back to familial categories again instead of classical categories, because we cannot classically categorize function in that way. So again, like, no matter how you look at it, the snake keeps eating its tail. We have doctors that are making the diagnoses, and we have researchers that are performing research based on the diagnosis. So it's like, okay, somebody has Alzheimer's. Okay, how do you know somebody has Alzheimer's? They're forgetful, they're forgetting things, they might have, some other symptoms of dementia or whatever. It's still symptom driven. You're not going to like cut into their brain and say, oh, this is happening. And even if you took everybody with Alzheimer's and you looked at their brains, you dissected every single one of them, you wouldn't see the exact same thing. You'd see a lot of variance. And so what we're seeing in the biology is not necessarily what we're seeing with the symptoms. And yet all of that's called Alzheimer's. And how many gut disorders are there that are exceptionally vague and not specific? How many gut disorders are just like, you have, like, I think like irritable bowel disease is like one of the biggest ones. It's like, yeah, I have irritable bowel disease, or I have constipation. I mean, it's just like, all right, it's either referring to something that's functional or dysfunctional, which I've already talked about why that's a priority error. And so then it's like, well, we can start trying to look at this more classically, and we could see, okay, let's try to find certain pathogenic bacteria that may be leading to this. Well, by the time we confirm something like that, it's just like the flu. Like we got to find a biopsy and we got to run it through PCR. We got to do all this stuff. And then with gut health, it's not like the flu. It's not like it's going to be over in a week. With gut health, people can get sick for years and, just kind of have to live with this. And then it just, they just have to suffer. And some people never get better. They suffer their whole lives with some of this stuff. And it's like, well, I guess that's just how I am. So what do we do? Like how much H. pylori do you have to have in the upper gut before you quote unquote have H. pylori overgrowth? Like what is the threshold for overgrowth?
We don't know. There's no quantification of that. There's no quantification of that of almost any disease.
Yeah. And that's a problem because that's how science works, right? They have to somehow simplify things into some sort of a numerical value so they can run statistics on it, right? Or they can show correlation. Otherwise, it's kind of vague.
I mean, someone goes like when someone comes to me with upper gut dysbiosis, symptoms of a peptic ulcer or reflux or bile, production issues and fat digestion issues, stuff like that. You usually see the same bacteria that show up because they generally colonize that area, whether it's Provotella or Citrobacter or H. pylori or Enterobacter. But you never quite really know, even if you get positives on a stool test, that is the exact bacteria as the cause for their issues. You have to at least try to, it's like I always say, with no test results, it's like throwing darts at a dartboard blindfolded. And getting the test results is like taking the blindfold off. It's easier to hit a bullseye, but you could still miss.
Mm-hmm. For sure. I mean, yeah, it's having more data is always good. Doing more tests is always good. But usually before any of those tests are done, they try treatment first. It's like, well, let's try this and see if it goes away. And if it doesn't,
and I've done that.
That's when when it doesn't happen. Okay, well now we need more data. It's like, well, it's obviously not this. So, it might take 2 or 3 tries. Well, if it's not this, then it could be this. All right, let's try this treatment because treatment's so much faster, right?
But isn't the difference between what you and I do and what conventional or allopathic, as far as what they do, is okay? You have ulcerative colitis. Let's try to have you avoid ruminant animal products. Maybe take some antimicrobial herbs, or have your doctor, try these antibiotics for a period of time,
Mm-hmm.
and then maybe take these supplements to reduce gut inflammation to see if you improve. They just go, well, let's try to handicap the body's immune system, and let's try with some 5-ASA first, and if that doesn't eventually work, then we'll try you on corticosteroids and biological agents. Isn't there a big difference between those two?
Yeah, I think though that there can be a partnership, and you can work with a client.
Yeah, it's called integrative medicine.
Yeah, for sure. I mean, and you can, because I cannot prescribe medication.
And we can't treat anything either. We can only give protocols and advice. That's all we can do.
But there are some lab tests, and we can link to these in the show notes, where you've got these, you can now order a lot of lab tests on your own. And I do this a lot too.
As long as you don't live in the state of New York.
Oh, really? I did not know that.
Yes, you're not allowed to order tests for yourself in the state of New York.
Wow. Well, can you just
the doctors, it's so strong there. Like you can't even get physical therapy without a doctor's prescription. We're here in North Carolina. I can go to a physical therapist, and have insurance pay for it. I can go to a physical therapist, and and my insurance will pay for it without having to have a prescription. So.
Well, just take a train to New Jersey then and get the test done.
or if you order a GI Effects stool profile, hopefully you have a family member that lives in New Jersey that you can mail your sample from and get the results back from.
So are they allowed to do? I mean, they can't do uBiome, they can't do 23andMe. Are there any? They can't do any of those tests.
I'm unsure about those. I think that for a while, 23andMe you could not.
Wow.
But I think they've changed that since then. But yes, most tests, like you can't order like LabCorp tests. A doctor has to write a prescription for those. You could not do that out of pocket yourself. Or North Carolina, I can. It's very easy.
Well, I still think that with people who are doing coaching, they're still very action based, and their description of pathology is still meets that criteria. And so I think there's a real danger where people convince themselves that they're scientists when they're not actually scientists, and they start trying to behave differently. Now, you can use science for sure to make good decisions and to make good recommendations, but we got to be very careful based on our categorization, what we're doing, and the purpose of what we do. Like, you get a client that comes to you and they have all these problems. Okay, you're not going to approach it like a researcher and be like, okay, this is going to be a clinical trial. We're going to do this double-blind thing. I don't really care about the outcome. I'm just going to see what happens. Like, no, you have an outcome in mind. You want them to get better, or you. I hope you do anyway.
Yes, I do.
Yeah.
You too.
Yeah. It's this. You're not doing a science project here, all right?
No. There are some people where I try experimental methods and I let them know, and sometimes it works and sometimes it doesn't. That's how it is. But yeah, I mean, it just depends on the person, and it depends on their situation.
Well, I think the other thing is in medicine, I guess a positive outcome is reached way more than in scientific research, where usually their hypothesis is disproved. And so you don't, like, we could say, oh, well, why not just have scientific researchers do the medicine and, leave out the doctors? Well, that would not be good for most people. Like getting better.
But I mean, but like we say, when we term getting better for conventional medicine, that's very good for acute diseases and for accidents. Very poor for chronic conditions.
Yeah, I mean, well, for sure. I mean, look, if somebody comes into the emergency room and they're like, I got shot, okay, we're not going to really have the same kind of discussion about like, well, is this really a classical categorization of, no, like you can look at it and be like, okay, this guy, there's a bullet lodged in his arm or whatever. You know what I mean?
You know what I mean? Like when it comes naturally is better with most of the time for chronic diseases and can't help with acute. But for example, I can't give you any amount of supplements or herbs or anything like their lifestyle changes if you got shot.
Well,
you got to get the bullet removed and
but that kind of stuff. But that kind of stuff, like allopathic medicine seems to do a much better job with.
Oh yeah,
because it's easy to categorize a gunshot wound or a stabbing or you hit your head or something. It's like, oh, you're not trying to guess what's causing this pathology. You don't need a scientific research team to see, that somebody just, had something terrible happen to them. And you're like, okay, well, we got to fix this right away. And so that's where I think that's where the medical field really shines, is with emergency care. Well, I mean, in general, sometimes they make mistakes on x-rays and whatever, but like, I'm just talking about in general, like, you get injured like that and you're not going to go to a naturopath and be like, hey, I want you to rub some PQQ on my bullet wound. But I mean, some people out there would tell you to do that. They'd be like, oh, well, I mean, I'm not going to name names, but like this one guy's like, IV vitamin C is a cure-all. He's like, no one's ever died without a vitamin C deficiency, and you can't prove otherwise. And so if somebody comes in with gets stabbed in the lungs with a knife or something like that, I'd be like, all right, vitamin C it up, and
I mean, this is ludicrous. You got to have it integrative on both ways. Now, there's some things that you can give to somebody to help improve their outcome from getting stabbed, to help with tissue repair and stuff like that, with maybe L-glutamine or vitamin C and stuff like that for collagen production and stuff. But you still might have to treat it with antibiotics, or you might have to, if they get shot, you have to surgically remove the bullet if that's possible. I mean, it's just, you can't treat or you can't even tackle everything, naturally. There's a reason why conventional medicine exists. There needs to be a bridge between the two.
Mm-hmm.
That's what people don't realize. When I say that I'm a naturopathic author and health coach, they automatically go to, well, you don't believe in conventional medicine? No, I do. And you and I have even had podcasts where we've talked about the flaws of naturopathic medicine and supplements. They're there just as much on the other side too.
Yeah, I think so too. And I think a lot of it is a balance between what's regulated and what's not regulated. There's a lot of advantages to having things that aren't regulated, but then that dysregulation causes a lot of problems on its own. But just understanding, I guess, refocusing here on I guess, the disconnect between scientific research and medicine, and where they just don't seem to have, it seems like, they would just have like the strongest connection. The researchers are pumping out stuff. The doctors are like, oh, great. And we'll use this and then whatever. And it just doesn't seem to work that way. And, I've tried to address it from this angle of, how scientists think of the world versus how doctors think about the world, and, what their job is, are very different. And those differences, I think, or what's causing the conflict, not necessarily that the doctors don't have access to the research or that they don't care or whatever, because every doctor I've ever met, they even the ones that are quote unquote bad doctors, they're some of the ones with the biggest egos. They want to get it right. They want their patients to get better. It's like an ego driven thing. So
it's not for me. No, I had the head pediatrician at the hospital at Kafer Valley tell me that Abel's better off dead, Jason.
Okay.
I mean, it ain't always like that, Bo. I'm sorry. I've seen it time and time again. I know we're talking about personal experience and history here, and that can cloud judgment, but for me, it's the complete opposite.
Well, maybe you just move out of the sticks and
No, it was even like that in UNC Chapel Hill. I had a doctor tell me that 100 milligrams of magnesium that was going to be given for Abel to help move his bowels and to help relax him and give him help a little bit with his contractures. That would cause him to be able to barely function because of the dosage of him being 1 year old, and that they give magnesium to women who are going through preeclampsia, and they get so exhausted from, the magnesium causes them that they can barely move sometimes. And even though his neurologist had prescribed that 100 milligrams to him, this doctor still wanted to lecture me on how harmful that 100 milligrams was going to be to my son. And I just laughed in her face. They ain't all knowledgeable, Jason. They ain't all good. I'm sorry.
Well, it is what it is. I'm not addressing the degree of knowledge. What I'm addressing is their care about the results that they're getting. I guess there's probably right. Doctors that, I don't know, they're not passionate about what they do, and they punch the clock, and they get the check and whatever, go on vacations. But I think most doctors are not that way. I think most doctors are result driven.
I agree.
They're looking to get the best outcomes, and I think that they're going to do whatever it takes to get those outcomes. And I think that it's not that necessarily that they're not looking at the research or that they have biases in other areas or whatever. It's just sometimes you do what you know, and you do what's worked for you in the past.
But it's not working. For a lot of these chronic conditions, it's not working.
Mm-hmm.
Acute conditions, yes, sure. I'll go with you.
Well, if somebody 100%. Has a chronic condition and you don't think you can cure them, what's the next best thing?
Remission. But remission at what cost? I mean, we've talked about, and I'm not saying that we're perfect either. There've been cases where people haven't been able to receive remission, and they can't figure out why or whatever. But I mean, when people are suffering from MAP, for example, ulcerative colitis or Crohn's disease, all they do is just hinder the immune system. They don't, just to achieve remission, it's a means to an end, but they're not doing anything to tackle MAP. That they're not. Now you'll say it's because they don't, dude, I've coached people where gastrologists are so blind. It blows my mind about how blind they are. I had one guy who I coached. He had all the symptoms of H. pylori, Jason, all of them, ulcers, reflux, everything. And yes, the stool antigen test the doctor had given him was negative, but the doctor decided to give this 24-year-old gentleman a nice and fun depilation. As soon as I got him on anti-H. pylori protocol after he contacted me, no issues whatsoever, went in complete remission. You and I both know that niacin was useless.
Well, I think that when you say use the word remission, well, what is remission?
Asymptomatic.
Okay, all of the symptoms or just enough of the symptoms to where they no longer fit the diagnosis criteria?
I would, in perfect world, all of the symptoms. For him, it was everything. He had no reflux. He had no stomach issues. He had no gastroparesis. Nothing.
So even when we talk about remission instead of cure, we still are talking about this idea of like what is healthy and what is pathology. At what point did we do our job and the patient's
Well,
good
the
to
reason why
go?
I can't say cure for one, that's against the language, but for H. pylori, you know that even if you reduce the amount and get the immune system working properly to tackle the dysbiosis and get the environment of the stomach better, whether it's to decrease the pH of the stomach or the microbiome of the stomach, H. pylori still exists there. You can't completely eradicate it.
Mm-hmm.
You know that.
Right. And so then the pathology is not necessarily the H. pylori, it's how much and where and what are they doing. And so but then all that relates to the symptoms again. It's like, well, you can have, a patient can come in with H. pylori everywhere, but they have no reflux, no ulcers, no gum disease, and they're good, as far as everybody's concerned, like they're good. Because like, look at it this way. When we use biomarkers instead of symptoms, which is perfectly fine. I'm not saying that that's not reasonable. They look at everything based on a normative, right? If you've ever had a lab test, then you get all these numbers and they tell you if you're in range or if you're out of range. And that's supposed to be normal and everything out of it is abnormal. Well, what's normal for you is not necessarily normal for everybody else. And
Yeah.
that's what people fail to understand is like, okay, you could have somebody come in with just a stomach full of H. pylori, and they don't have any of the symptoms, so they don't match the symptom criteria. But from the biomarker point of view, they're unhealthy, they're sick. And so, what is normal, what is healthy, what is not healthy? That's a hard question.
It's all relative, isn't it?
Well, yeah, I mean, you get these people, like say you get this guy who's he's just this diehard Marine, and he's got, he goes to work and goes in a crosswalk, gets hit by a car, shatters his shoulder, does his job. Is he in pain? I mean, he would tell you, no, I'm fine. I'm not in any kind of pain. I'm good to go. Just finishes the whole workday, lives with that injury for years, never complains about it. Right. So in one degree, it's just like, how sensitive are we to the symptoms? Because like if you looked at him symptomatically and said, hey, are you experiencing any pain in your shoulder? No. But you give him an x-ray. Oh man, that thing's not looking good. That's definitely, several compound fractures here, whatever, and it's just, it's just really bad. So, I mean, that's kind of like severe and maybe not a practical example. But I guess the point I'm trying to make is that like, for us to even understand that we're suffering, we have to have a perception of ourselves, and like, are we sick? Do we recognize that sickness? Like you could have somebody that is super constipated, but doesn't even notice. It's like, when's the last time you've gone to the restroom? I have no idea. Like, I don't pay attention to that. I'm busy. I've got a hard job. And people aren't going to notice that. There's a lot of things that people don't notice about their health. So at what point does the suffering make it bad enough for them to have to go to the doctor in the first place? And then what does the doctor do about that suffering? And then how does that tie into research? There's just a lot of problems. And I don't disagree with the way doctors are doing familial categories. I think it's effective for what they do. I think it's very powerful that we have a name for their disease. And so, it makes the patient feel a lot better. I have no problem with the classical categorization used in scientific research. I think that is essential. I think if you tried to use familial categorization in scientific research, it would be a complete failure. Then you wouldn't be able to do anything. But I think that the differences in the way that these people look at the world, I think it causes problems. And I think that is, in my opinion, the biggest problem and the biggest disconnect between the two is because they each have different ways of looking at problems. Or, I guess scientists yeah, I mean, it's just they just have different ways of seeing things and different ways of doing things. And so how do we bridge this gap in between, doctors and science? Well, first of all, we have to recognize that there are differences in what they do and what their goals and objectives are. And I don't necessarily think that that we're making that. I think a lot of doctors think that they're scientists, and I think that a lot of scientists think that they're doctors, and that's a big problem to me.
Yeah, I can definitely see that. But I do think there needs to be a bridge of communication between research and the medical profession.
Yeah, I mean, we definitely, I think, could improve the state of healthcare if we could figure out how to reformat the scientific research so that it becomes classical. So maybe have different scientific terminology and not carry over the medical terminology into the scientific research. I think they need to have their own terminology. And I think that what you name something is very important, and how you name it, it has function behind it. You named it this way because you're trying to treat it, or did you name it this way because you're trying to understand it? And it's two completely different things. So, I think that perhaps science and medicine need to disconnect from each other for a little while, even further, and then kind of like settle things up, and then they can start working together once we clear up all the terminology.
Yes, very much so. Hopefully that can be achieved one day.
Yeah, but it's just going to take a lot of work, because we're going to have to go completely restructure the framework of everything. We're going to have to separate everything out, isolate it, and then and that's going to have to be done from the science vantage point instead of from the medical vantage point, because in the medical stuff isn't gonna change. Like, they're not going to change influenza, they're not going to change cold. Like, the terminology they're going to use is going to stay the same. It's going to have to be done from the scientific point of view. Like, they're going to have to change the way they research and the way they name things.
Yeah, I just don't ever really see that ever happening. But it'd be nice if it did.
Well, then the snake's going to continue to eat its tail, because there are big problems with the ways that we're doing this. And I think that's why, it's gotten us to this point, and we're pretty advanced. I think, medicine's better than it's ever been before. I don't think anybody can argue that point. But to make the next huge progression, I think, in medicine and in understanding, is going to have to be to make these perceptual changes. We have to change our perception about terminology and the words that we use that are important, because they, the function that's ascribed to them has a meaning. It has a meaning because, whoever made that word did it for a certain purpose, and it was that purpose to understand the world, or to create an action to treat whatever that word is. And if you look at all of medicine, everything, every just about everything in there is, familial categorization, and not a whole lot of classical categorization. A lot of the things that we think are classical categorizations, like, okay, well, we definitively know that you have the flu. Well, that again is like, well, it goes on, what is pathology and what is healthy, and does everybody who has the flu virus have the same symptoms? Do they have enough of a issue to where they even go to the doctor in the first place? So it's just there. We have to resolve all of this before we can make the next big step in healthcare, I think.
Yes, I definitely agree with you.
Well, I guess we'll go ahead and wrap it up with this one. I don't think we solved anything, but I just kind of wanted to discuss this, just get some ideas out there and just kind of throw a bunch of spaghetti on the wall and see what sticks.
Hey, we at least shine light in places that people may not have thought about. So
yeah,
that's a step forward in the right direction.
Yeah, and I might be off the mark too. I mean, who knows? But I definitely see some problems with terminology, and I think that there's a lot of room for improvement there.
Yes, very much so.
Well, everybody, thanks for listening, and we'll catch you the next time.